Good morning, everyone, and thank you for joining us. We're pleased to have so many of you with us this morning. My name is Dr. Lisa Dennison. I'm from the UT Southwestern Office of Development and Alumni Relations, and I'll be serving as your moderator this morning. I have just a few quick housekeeping notes to get us started. First of all, thank you to everyone who submitted questions ahead of time. We've tried to incorporate answers to as many of those as possible into the briefing itself, and we will ask some of those questions to our speakers at the end. If you have any questions throughout the talk, please go ahead and submit them in the chat, and we will go through those and ask as many of those as we can get to at the end as well. So that's all I have for now. With that, it's my pleasure to turn it over to the president of UT Southwestern, Dr. Daniel Podolsky.
Good morning. I'm very pleased that so many of you are joining us this morning for this COVID-19 briefing. Let me begin by simply giving you a highlight of the agenda. In a moment, I'm going to turn things over to Dr. Julie Trivedi. Dr. Trivedi is an associate professor of internal medicine here at UT Southwestern and a specialist in infectious diseases. She also serves as the medical director of infection prevention in the UT Southwestern health system, and has been one of the key experts at UT Southwestern that has helped inform our practices over the course of the last year and a half as we've navigated this really unprecedented pandemic. So Julie will provide an overview on where things are in the pandemic generally, and then more specifically here in North Texas. And after we've heard from Julie, I will take the opportunity to share with you the projections that have been formulated by our multidisciplinary modeling team, which has worked together, bringing experts from data science, computer science, epidemiology, infectious diseases, and others, with the benefit of a supercomputer here at UT Southwestern to project future trends of the pandemic. And over the course of time, those projections have really proven to be remarkably close to the subsequent course of the pandemic. So thought we would take advantage of the opportunity to share with you the most recent projections as to what we expect in the weeks ahead. Finally, so that I don't neglect to do this later in the hour, if you do have questions in the course of this briefing or at other times, I want you all to be aware of a resource, COVID-19 support at utsouthwestern.edu. That email address is an access to have your questions answered from experts here at UT Southwestern. Also to make note of our website, where updates to the model projections are posted publicly twice a week, and other updates are provided on a daily basis. So with that, I'm going to turn things over to my colleague, Dr. Julie Trivedi, and ask her to provide us with an update on the COVID-19 pandemic. Julie?
Thank you, Dr. Podolsky. Good morning, everyone, and thank you for joining us this morning. And again, thank you for the opportunity to be able to present this information to you. So what we're going to start with is to go through an overview of the trends that we are seeing across the US and then in Texas as well. So this is a map here that is showing basically a list of all of the hotspots across the United States. There are many counties within the South, as well as part of the Pacific Northwest, where you see the darker colors. And the darker the color, basically what that means is that there are more cases per 100,000 individuals over the past 7 days that are being reported. And so, you know, the numbers actually go up to over 200 cases, 250 cases per 100,000 individuals. What we're looking at on the right side basically is a graph that is showing the number of hospitalizations as well as the number of cases overall in the United States. So the red graph is showing the trend of new cases being diagnosed basically since the beginning of the pandemic. And we can see that over the past 18 months or so, there have been many peaks and valleys, and we are currently still at one of the higher areas as far as the number of new cases being reported. possibly with a slight downtrend, but it remains to be seen how things evolve over the, the recent Labor Day weekend. The smaller graphs underneath the red one are basically showing the number of tests that are being performed. The middle graph is showing the number of hospitalized patients. And then the last one is a graph talking about basically how many individuals have died and the trends in the deaths. What we know is that anyone who is presenting to the hospital today was infected around 2 weeks ago and possibly earlier than that. And so we tend to see a lag in when the hospitalizations occur compared to when the diagnosis or the infection occurs. And then we also see a slight lag as far as when the death occurs relative to the hospitalization. So we are now entering that time frame where we are beginning to see many deaths from individuals who have been hospitalized from COVID-19. Next slide. Next slide. Yeah. Thank you. So this is a map basically comparing, the one on the left is looking at current hospitalizations across the United States, and then the one in the green is basically looking at vaccinations. So there are a few things that I want to point out. The hospitalization, so the darker the red color is, that means there are more COVID-19 patients hospitalized per 100,000 people in those regions. And we can again see many areas within the South, it's just Florida, counties in Texas as well, that have pretty high rates of hospitalizations occurring. The map on the right side now is showing the percent of residents that are 12 and older that are considered to be fully vaccinated. And so the darker the green here indicates that there are higher percentages of individuals who are fully vaccinated. So we can see that parts of New England, the mid-Atlantic areas near Michigan and Chicago, Illinois, as well as parts of the desert Southwest and maybe even some southern parts of Texas, Florida, and then the Pacific Northwest have pretty high vaccination rates where almost greater than 60%, and in some regions, 70 to 80% of individuals over the age of 12 are fully vaccinated. And the importance here is that when you look at the regions of the map where you have high vaccination rates, those are the similar regions on the map where you have lower hospitalization rates. And so this kind of shows what we've been saying, and what we know is that lower vaccination rates areas result in higher hospitalization rates. You go to the next slide. So now focusing on the state of Texas, this is a map of all of the different counties in the state of Texas. And again, showing where the hotspots are. The darker the red color, we are seeing over 100 to 250 cases per 100,000 individuals in the past week. Our 4-county region over here with Dallas County, Tarrant County, Collin, and Denton County are in the middle orange. So we're seeing anywhere from 40 to 60 cases per 100,000 individuals over the past week. The graph on the right is mirroring what we had seen in the previous slide, or the previous 2 slides, regarding new cases being reported in the state of Texas. We are approaching, and hopefully flattening, but approaching where we were in the winter surge. And as expected, we have seen a pretty significant increase in the number of tests that have been performed over the past 14 days, with an over 1,000% increase. And then based on the hospitalization rates, there's been a 47% increase in the number of deaths over the past 2 weeks compared to previous to that. And currently, from what we know, 49% of intensive care unit beds are actively being used for the treatment of COVID-19 patients. These are not patients who are hospitalized for other reasons and found to have COVID-19, but they are in the intensive care unit because of COVID-19. So what we have as far as our current hospitalization numbers here at UT Southwestern, as of this morning, there were about 62 patients hospitalized with COVID-19. About 14 of those are in the intensive care unit. We also have 2 other partner institutions where our faculty and trainees participate in the care of patients. One of those is the Parkland Health and Hospital System. There we have about 150 patients who have been hospitalized with COVID-19, and about 35 of them are in the intensive care unit. When we look at children's, and this has been in the news in many regions of the country, we have been seeing unprecedented numbers of children being admitted to the hospital either for COVID-19 or then incidentally found to have COVID-19 on admission for other reasons. This has placed a pretty significant demand on the available beds for children, as well as the intensive care unit beds. Many of these children who have COVID-19 were also found to have infection with other respiratory viruses, such as RSV. And they've also been children who are actually eligible for vaccination, but have not been vaccinated. And so this is something that we've been seeing in the intensive care units at Children's. Next slide. So when we look at our current trends then in Dallas County and in North Texas, currently in the state of Texas, the overall percent positivity of all of the tests being done for COVID is about 15%. And this number continues to fluctuate. It depends on how many people are seeking out testing. And then the graph on the right side is basically a trend of the confirmed COVID-19 patients in North Texas hospitals. And what we're seeing where we are currently is that hospital volumes continue to increase. We're about 8% higher than where we were 1 week ago, about 17% higher than where we were 2 weeks ago, and about 95% higher compared to where we were 1 month ago. Next slide. So this is an interesting tool that we thought might be of interest to many of you based on some of the questions that you've all asked. This is a risk assessment tool, basically that can help assess the risk of a COVID-19 person who is infected being present at a gathering of different sizes. So basically this tool allows you to focus on your county and taking into consideration what the risk level is in that county based on the number of cases that have been reported, it helps to estimate the chance of a COVID-19 positive individual being present. And so when we look here, for example, a gathering size of about 25 people, this would be the size of a classroom in school. We can see that in Dallas County, there's a 44% chance that at least one individual in that classroom or in that gathering size will be COVID-19 positive. In Tarrant County, that percentage is a little bit higher to almost 50%. And as we increase the size of the gatherings, let's say to 100, there's about a 90 to 93% chance that at least one person will have COVID-19. And I think this really helps us understand that when we are in a public space or when we are at a gathering, what is the risk of our exposure to other people who might have COVID-19? Next slide. And so moving on to the variants, the most highly transmissible variant, the most highly transmissible Delta variant is currently the dominant variant. This is a map from the CDC and specifically looking at Health and Human Services Region 6. The states included in that are Arkansas, Louisiana, New Mexico, Oklahoma, and Texas. And what we can see in this map is that from the left-sided graph, which is around early June, you have more of the graph is made up of this blue color, which is the B117 variant. So this is known as the Alpha variant, the one that was originally identified in the UK. But as the Delta variant, which is the B1617.2 and many of its sublineages was introduced in the country, it quickly began to become the dominant variant due to its more infectious nature compared to the Alpha variant. And so most recently in this region, and this is really reflective of what we're seeing in the United States overall, the Delta variant represents more than 99% of all of the cases in Texas and its neighboring states. And those numbers are also mirrored with the sequencing efforts that we have been carrying out here at UT Southwestern, where we sequence basically all positive specimens that come in to our institution. We have identified a handful of other variants of interest, such as the Mu variant, as well as the Lambda variant. But currently, those variants are outnumbered by the Delta variant. Next slide. And this is basically a map looking at the global prevalence of not only Delta, but a few other notable variants that we have seen elsewhere. So currently in the world, Delta accounts for about 94% of all sequenced cases. And the graphs at the bottom show that Beta, even at its peak, really only made up slightly more than 2% of cases. And that number, that percentage has quickly dropped as Delta has taken over. Lambda and Mu are the variants that were identified in Peru and then Colombia, respectively. And again, both of those have had a very low prevalence, about 0.5% of all of the variants were due to those. And again, those percentages have continued to decrease as Delta has continued to spread. Next slide. So then moving on to vaccinations, where are we in this vaccination, in the vaccination status? So COVID-19 vaccinations in the United States have been increasing. And we look at two main groups, those that are 12 and older, and then those that are 65 and older. And with the 12 and older age group in the United States, about 62% of people are considered fully vaccinated. We define that as somebody who has completed both doses of an mRNA vaccine, which are the Pfizer or Moderna vaccines, and is 2 weeks after their last dose, or people who have completed the one dose of a Johnson & Johnson and are 2 weeks again after that dose. So that's the definition of fully vaccinated. We see higher percentages for those who are 65 plus, around 82%. And then when we look at the Texas as a state overall, we have slightly lower percentages of individuals who are fully vaccinated. So 58% and 78% for those two age groups. And then our counties kind of mirror the same numbers as far as what we're seeing in the state of Texas. Anywhere from 58 to 68% of people 12 and older are vaccinated. And then anywhere from 76 to about 85% of people over the age of 65 are fully vaccinated. And you can see on the map here that the darker teal colored areas are areas that have really high vaccination rates. Next slide. And so, the biggest question that many people have is how effective are the vaccines against the Delta variant? So this is a slide that what I'm going to take you through is basically different studies that have looked at the different vaccines. And so these are some of the data that have been reported from other countries in addition to the United States. So first, the blue bars are basically the Pfizer vaccine. The green bars are the Moderna vaccine, and then the red on the right-hand side is AstraZeneca. We do not currently have AstraZeneca available in the United States. This has been available predominantly in England and many other countries around the world. So the graph on the left side is looking at how effective the vaccine is against any infection, whether somebody was symptomatic, not symptomatic, whether they were hospitalized or not. So overall efficacy. And what we're seeing is that in the country of Qatar, they reported about the vaccine being about 60% effective against any infection overall. That percentage is slightly lower, but it has still a wider range in the United States, about 42% efficacy. When we look at the Moderna vaccine in Qatar, that vaccine efficacy is reported to be around 86%. And then in the United States, that's about 76%. Our time frame for efficacy in the United States was through the end of July, and we certainly know that there's been a lot more data and a lot more cases that have occurred in the months of August and so far in September. But the main thing that I wanted to point out from here is looking at the efficacy against hospitalization. And what you can see overall is that the percentages of how efficacious the vaccine is against preventing hospitalization when someone has been infected with the Delta variant are really high. And this has really been the main selling point of the vaccine so far. So data from England, Israel, and Qatar are really showing anywhere from 88 to 98% efficacy against hospitalization if someone were to be infected with COVID-19. Similar percentages for AstraZeneca in England. And then in the United States, we've seen about 75% efficacy with Pfizer and then 81% efficacy with Moderna. Of note, we don't know in the United States when people have been hospitalized if there is a lower threshold to hospitalize individuals or if people here are sicker maybe because of some other comorbidities they might have, such as obesity, diabetes, or being immunocompromised overall. So we don't have any data, actually. I saw there was a question in the chat that just came through about Johnson & Johnson. So I don't have any formal data from other countries reporting efficacy against the Delta variant from Johnson & Johnson, but the reports are so far that the efficacy is quite similar to what we're seeing with Pfizer and Moderna. Next slide. And so really the main thing that we want to relay here is that vaccination reduces the risk of disease and hospitalization as well as death from COVID-19. And the first set of bars here are basically the blue are people who are vaccinated and the green are individuals who are unvaccinated. When we look at the weekly incidence of COVID-19, so the number of cases per 100,000 individuals, we have seen that there are 8 times more individuals who were found to have COVID-19 that were unvaccinated compared to vaccinated persons. When we look at the hospitalization rates, about 25 times more individuals were hospitalized for COVID-19 who were unvaccinated than those who were vaccinated. And a similar increase in the risk of death as well for unvaccinated individuals compared to vaccinated individuals. So the main take-home points here are that although the vaccines may not be 100% at preventing someone from getting infected with COVID, they are quite effective at preventing somebody from being hospitalized for COVID-19 or even dying from this disease. Next slide. And so some of the questions are, with breakthrough infections. We've been hearing a lot of information in the news lately about the viral loads in people who are vaccinated versus unvaccinated, and how some of these data that came out from studies that were conducted, in Provincetown and et cetera, looking at outbreaks, really led the CDC to shift its guidance regarding masking for those people who are vaccinated. So there's a few points from this slide here. Basically, these 2 lines are looking at healthcare workers, those who were unvaccinated, and these were individuals who were infected with COVID-19 in the earlier stages of the pandemic, so not infected necessarily with Delta or even Alpha, and then looking at vaccinated individuals. And so these are people who would have been identified after February when we began to see Alpha and Delta. We know that Alpha and Delta were significantly more transmissible than some of the original variants of COVID-19. And so what the y-axis here is showing is the probability that the sample that was collected from the person contained live virus. So this is virus that's considered to be infectious. And then the bottom, the x-axis here is showing what is that viral load. So how much of that virus is present when they collected the specimen. Overall, some of the conclusions here are that in general, vaccinated people have a lower amount of infectious virus compared to unvaccinated people. And what we know is that the higher the viral load, the higher the chances that some of that virus might actually be infectious. And this is also what contributes towards mutations occurring as well, which can then lead to variants and variants of concern. The other take-home point is that viral loads have also been shown to decrease faster in vaccinated individuals. Now, this is some data from Israel that is not presented on this slide here, but we have shown that basically, even if vaccinated healthcare workers had high amounts of virus in their nose, more of that virus was not infectious, and then the amount of that virus actually decreased faster than in people who were not vaccinated. Next slide. And so, when we look at the vaccine efficacy, we've been talking about, Delta and then the different vaccines. So here we wanted to look at efficacy against hospitalization for different types of populations in the United States. And so what we're seeing here is that when we look at all patients, the light blue are basically people who are 2 to 12 weeks after vaccination, and the dark blue are people who are 13 to 24 weeks. So that's, when we start entering the 4 to 6 month after vaccination. So for the cumulative public here, looking at all patients in the first 2 bars, basically the vaccine is about 85% effective against hospitalization, regardless of when that person received their vaccine. So either in the earlier phase or even the later stages after vaccination. When we look in the second set of bars where people are aged over greater or equal to 65 years old, we are seeing a slight decrease in the efficacy of the vaccine once they're at 4 to 6 weeks out, 4 to 6 months out, sorry. And that efficacy has decreased to about 80% from about 85%. The third set of bars is our immunocompromised patient population. We know that currently they are eligible to receive a third dose to help boost their immune response. And part of that is because even when folks had just recently received their vaccine, so in that 2 to 12 week range, there was probably about 65% efficacy at preventing hospitalization. And then that percentage has decreased further to about 55% in immunocompromised patients over time. And then looking overall at people who have multiple underlying medical conditions, the efficacy has been around 75 to 70%, with only a slight decrease really out 4 to 6 months. Next slide. So regarding boosters, what do the data show? So just to clarify some terminology, what the dose is being recommended for immunocompromised individuals is considered a third dose because it's thought that many of these people may not have actually even mounted an adequate immune response to either of the first 2 doses of the vaccine if they received the mRNA vaccine. And then the boosters would be for individuals who are not immunocompromised, and this would be, the rest of your general public as far as the third dose is concerned. So these data here are showing that basically 1 month after they received their dose number 2, the light blue, the light green are people who are infected with wild type virus, and then the blue are people who are infected with Delta. And what they found is that after 1 month after dose 2, there was basically a slight, really a slight decrease in the amount of neutralizing antibody for the 18 to 55-year-old age group. And that 1 month after dose 3, that antibody response increased pretty significantly. So it went from an average of around 310 up to over 1,547 against wild type, and then from 241 to 1,321 for the Delta. And so this is basically more than a 5-fold increase in the titers, the neutralizing antibody titers after individuals received their third dose, specifically for the Pfizer mRNA vaccine. When we look again at the 65 to 85-year-old age group, we can again see that after dose 2, there was a slight decrease in the amount of neutralizing antibody titer, but then once they received dose 3, that there was a significant increase, about an 11-fold increase in the dose of antibodies, in the amount of antibodies after the third dose. And so really there's an estimated potential with the Pfizer vaccine with receiving a booster that there could be up to a 100-fold increase in the ability to neutralize the Delta variant after dose 3 compared to after dose 2. And so these were second quarter earnings that Pfizer had released. We don't have basically the same type of data yet for Moderna and then even for Johnson & Johnson yet. Next slide. So what is the status now of boosters? So the third doses of mRNA vaccines for both either Moderna or Pfizer are already authorized by the FDA for immunocompromised individuals. The CDC and the Advisory Committee on Immunization Practices has released kind of what the criteria are for who is considered to be immunocompromised. And then the Advisory Committee is currently evaluating when boosters will be available or when they should be given for the general public. The administration has mentioned September 20th. The FDA is still currently reviewing data, and so it's a concern of whether or not anywhere from 6 to 8 months after the second dose, people might be eligible to receive that. But they're still reviewing information to see how beneficial that will be. And hopefully we'll have some recommendations later this month. We do know that the Pfizer vaccine has received full approval. And then, some of the other vaccines, Moderna has submitted for full approval as well. And Pfizer is still under emergency use authorization for the 12 to 16-year-old age group. And so what we know is that, while boosters are important, they're really, vaccinating people who are already vaccinated. And what we really need to be able to do is focus our efforts on people in the United States who are not vaccinated yet, and then even globally to help many other countries around the world with their overall vaccination rates so that we can help to end this pandemic. Next slide. So I started to touch upon this already. Basically, this is the FDA approval status of the COVID-19 vaccines. So Pfizer, again, has full FDA approval for people 16 and up. They have an emergency use authorization still for 12 to 15-year-olds. And then there are trials that are underway for ages 5 to 11, 2 to less than 5, and then 6 months to less than 2. And they also have a trial underway that they're actually, I think, hoping to start soon for looking specifically at their vaccine against the Delta variant. Moderna has submitted their data for full FDA approval. And again, Moderna would be for ages 18 and up. They still have the emergency use authorization for 12 to 17-year-olds. And they again also have trials underway for children under the age of 12. And then it's expected that Johnson & Johnson will file for full FDA approval later on this year. And this is also 18 and above. And there are trials that are now underway for the 12 to 17-year-old age group and not yet underway for that younger age range. We are hoping that Pfizer will submit results of their clinical trials for the 5 to 11-year-old age group later on this month or early next month to be considered for EUA. Next slide. So, what are the risks of adverse events? There's been a lot of discussion about the potential side effects and adverse effects of getting a vaccine. And then really thinking about that in comparison to the risk of actually having COVID-19 and some of the complications that can stem from actual infection with COVID-19. So the yellow bars here basically are looking at the risk difference per 100,000 persons who become infected with COVID-19. And then this gray bars basically are looking at the risk difference in these adverse effects per 100,000 individuals for people who received the Pfizer mRNA COVID-19 vaccine. And this is a study that was published in the New England Journal, and the data are coming out from Israel, where they really looked at over 880,000 vaccinated people with matched controls and compared them to about 173,000 COVID-19 patients to look really at the risk of adverse events. And so some of the things that I want to point out here, the yellow bars that are the most notable are in this first one for acute kidney injury. So this is in somebody who might have then developed complications with their kidney function. The second largest bar is arrhythmia. So this is an irregular heartbeat or an irregular heart rhythm. Deep vein thrombosis is the bar that has the 43 above that. So that's a blood clot that can occur in the legs or sometimes in the lungs themselves. And then the other notable bars are for myocardial infarction, where there's a 25, and that's a heart attack, myocarditis, which is inflammation of the heart muscle, pericarditis, which is inflammation of the lining around the heart, and then pulmonary embolism at the end. So all of these things that I just mentioned had a really significant increase in the risk of developing one of these if you were infected with COVID-19 compared to people who were not infected with COVID-19, and then even in comparison to people who were vaccinated. Talking about the blue bars now for those who were vaccinated, two of the things that were seen to be slightly more common were possibly shingles infection, and the second one is lymphadenopathy, which are swollen lymph nodes. So really the adverse events associated with the vaccine are much milder, less severe, and then even fewer in number than the adverse events that can happen from somebody who actually becomes infected with COVID-19. There have been studies looking at myocarditis, which is something that has been in the news regarding the mRNA vaccines for individuals, usually like young males in the late teens. And what they have found is that, basically for about 70 cases of myocarditis can still help, if you vaccinate everybody, basically you're still preventing more cases of hospitalization and death than people who would end up developing myocarditis. And what we know with that inflammation of the heart is that the inflammation associated with the vaccine is actually more shorter lived and resolves faster than people who have myocarditis from COVID-19 infection itself. Next slide. So we wanted to focus a little bit now on treatments. There's been a lot of movement in treatments right from the beginning. And so what is proven to work so far on people who are not hospitalized? So people who are still out in the community have been diagnosed with COVID-19. The mainstay here really has been the use of monoclonal antibodies. This is a product traditionally that's been predominantly that's been developed by Regeneron. There have been other monoclonal antibodies that were released, some of which have no longer have their emergency use authorization because they're not found to be as effective against the Delta variant. And the monoclonal antibodies really have two areas for use. One is if somebody has been recently infected with COVID-19 and maybe based on their age or underlying medical conditions might be at risk for being hospitalized. So it can be given to those people within 10 days of symptom onset. And there are some monoclonal antibody infusion centers that have been opened up in the state and some in our region as well. They can also be used for somebody who has been exposed to COVID-19 with a known exposure and is at risk for severe illness or hospitalization. So if there was a family member that developed COVID-19 and somebody else in the household might be immunocompromised, they might be eligible to receive this monoclonal antibody treatment as well. And so when we look at hospitalized patients, what is it that we have here that's available for them? So remdesivir is something that has been approved by the FDA to treat hospitalized patients with COVID-19. And it's an antiviral medication that's been proven to help improve clinical outcomes. Usually these individuals also receive steroids if they have any type of an oxygen requirement, and this helps to reduce mortality or death in patients requiring oxygen. And then similar for some of these other types of therapies, such as baricitinib or tocilizumab, these are medications that have been used for other disease processes like rheumatoid arthritis, and they have also been found to help reduce the likelihood of death or mortality in patients who have an oxygen requirement. And basically all of these, the steroids, the baricitinib and tocilizumab, really work to help suppress the inflammatory response that's triggered from being infected with COVID-19. Next slide. There are also other clinical trials that remain ongoing. And there's a recent drug that basically was found to have a new purpose, maybe for COVID-19. So this is a medication, fluvoxamine, that has been used in the psychiatric world, I believe for depression. And basically there is a new randomized controlled trial that showed about a 30% relative reduction in the emergency room visits and hospitalizations for patients who have been given that drug. So it's still being reviewed, the literature is still being reviewed, but hopefully this could be an opportunity for an inexpensive oral medication that can be used for early disease. What we know that has not worked so far basically are chloroquine, hydroxychloroquine, azithromycin, and ivermectin. So there have been studies looking at this that show that these drugs are not effective in helping to prevent severe illness or prevent hospitalization, and they're not really effective in treating anybody who has COVID-19 anyway. Next slide. And on the note of ivermectin, the CDC has released a recent health advisory warning against the use of ivermectin. What they found is that many people are obtaining this from veterinary stores where some of these medications have been purposed to use in the animal, for animals. And in the healthcare sector, we do use ivermectin when we treat certain types of parasitic infections, such as strongyloides. We also use it to treat scabies sometimes. So there's a very selected use for ivermectin, at least in the infectious disease world. The clinical trials that have been conducted so far have not yielded enough evidence to actually recommend ivermectin for the prevention or treatment of COVID-19. But what the CDC has noted is that there have been a lot of individuals who have been using this. It's resulted in significant overdoses and toxicities. The toxicities can involve many different organ systems, such as severe gastrointestinal effects like nausea, vomiting, diarrhea. It can also affect the central nervous system, causing seizures, hallucinations, altered mentation, confusion, and dizziness. And then it can also affect people's heart rate and blood pressure. So there are a lot of toxicities that can be associated with ivermectin, especially when it's not clear what doses individuals are taking. And when we know that the doses that are given to large animals would be quite different than what would be suitable for a human. Next slide. So I wanted to touch upon long COVID. Long COVID is something that basically when you have persistent symptoms, at least one to two or even more months out after diagnosis. And so there's been a few studies that have looked at long COVID. The systematic review of about 45 studies found that persistent symptoms were common following COVID-19, and about 3/4 of patients reported at least one symptom 2 months after diagnosis. These symptoms could range from being fatigued, having this type of brain fog, or just not feeling like your normal energy levels are there, or even difficulty concentrating. Then when we think about children, there was a Norwegian study that found, not children just yet, but adults ages 16 to 30, there was a Norwegian study that found that more than 50% of people in this age group still had some type of a persistent symptom 6 months after infection. And then now looking at children, we're still in the early stages of having enough data on children, but there are anywhere from 2 to 4% of children who might continue to experience some lingering symptoms, even 3 months after infection. And so this really points out, the long-term sequelae of having COVID-19 infection are there, and we're still learning about the true impact on people over time. Here at UT Southwestern, we have an amazing program that was developed by our physical medicine and rehabilitation specialists called COVID Recover. And basically they've created this outpatient rehabilitation program, and it's really a type of a multidisciplinary approach to help patients restore their muscle function, lung function, brain function, mental health, and overall psychological well-being after being infected with COVID-19. We've had many patients referred to this program, and from what I can hear, there's been a lot of positive feedback from that. So if you are an individual who's had COVID-19 and are still dealing with lingering symptoms, or if you know of others, feel free to reach out to the program to see if this is something that might be right for you. Next slide. I wanted to touch upon this slide here. Schools went into session several weeks ago. I myself have children that are in school. And what we've been hearing across the state and even in many other parts of the country are the issues that have been there regarding whether masking is beneficial or testing, and what kind of measures can be put in place to really help our children return to school safely and be able to stay in school over the year. And so basically this was a mathematical model. It was a mathematical simulation. They looked at 3 different types of settings. The first set of graphs here is looking at low immunity. So these might be a middle school or elementary school where children are not yet eligible for vaccination, or it could be in areas where there has been a low uptake of vaccines, or in areas where there's not been a lot of immunity to COVID-19. And the 4 different scenarios here are the red one is basically when there are no masks put in place and no testing being done. And what we can see is that when you have a situation like that in a school with low immunity, pretty much by 3 months out, or actually 2 months out, about 91% of the students will become infected with COVID-19. So pretty significant numbers. Now, if you did not have a universal masking mandate, but you did have testing occurring on a regular basis, that percentage might decrease down to 79%, because you'd be able to identify children who might be positive for COVID-19, even either before they started to have symptoms or pretty soon after symptom onset. When you move to a setting where you have universal masking, even if you did no further testing, the percentage of students who would be infected by 3 months out would only be about 49%. I say only, not to say that that's a minimal number, but that's a pretty significant decrease from the 91% just by implementing masking. And then if you have universal masking as well as testing, you're able to bring that down to about 22%. So we can see that 30 days out from when the school year has started, you have much smaller percentages of children who will become infected with COVID-19 when you have universal masking, even if you don't have testing to go along with it. And then there are, settings in which you have medium immunity and then high immunity. And so we'll just put this information here. Next slide. There are resources on our website, which, by our specialists with Dr. Warner, answering questions and really talking about when vaccination might be helpful and to really answer some specific questions. We also have some blogs by some of our specialists on how do you address vaccine hesitancy with individuals in the community. Next slide. And then we do have vaccinations available here at UT Southwestern, even for walk-in appointments for anyone who is 12 years and older. So I think this is the last slide for me, and I will turn it over to Dr. Podolsky.
Thank you, Julie. A lot there for all of us to take in. Let me now share the latest update from the multidisciplinary modeling group here at UT Southwestern as it looks into the weeks ahead and the trends of the pandemic. We can go to the next slide. This provides some context that you will see in what's happened in recent weeks. I think many on this briefing call will certainly have seen coverage to know, and you've seen some of the graphs from Julie, that we are locally in a surge which is rivaling that we saw in the winter, which was the largest surge to date. And as we were heading into this latest surge, the projections included the possibility of far surpassing that. I'm pleased that we now see that some of that awareness has translated into action in terms of people taking responsibility vis-a-vis wearing masks. So what you're seeing on this slide in the upper panel is the percentage of individuals over the course of the last months who have reported or self-reported wearing masks. And you see that as we were in the early parts of the summer, it had substantially declined at a point in which cases in North Texas had substantially declined. But now in these recent weeks has rebounded, not entirely to where we were in the early months of the year, but approximating that. So, and in particular here in Dallas County, we're now 80% plus of individuals who are reporting that they are wearing masks, somewhat lower percentages, but nonetheless increasing in Tarrant, Denton, and Collin County. And in parallel with that, if you see in the middle graph, some increase in reporting that other people are wearing masks as individuals are out in public. Bearing this in mind, we'll see how it maps to the most recent trends in new cases of COVID-19. If I go to the next slide, this is a graph that I'm sure many have seen, but perhaps not all. And it is depicting the RT value over the course of the last several months. The RT value is calculated from the R naught value. The R naught value, or R sub zero, is a determination of how many people an individual diagnosed with COVID-19 will go on to infect. And I think it follows in a logical way that if I have COVID-19 and I infect one person and not more, the RT value will be 1. If I'm infecting more than one person, the RT will be above 1, and that will reflect the fact that more and more people are becoming infected with COVID-19. If I am on average, as a COVID-19 infected person, infecting less than one person, the RT will be below 1, and accordingly, the number of new cases of COVID-19 will be shrinking. So that RT, which is the R naught over time, is really telling the tale of whether the pandemic is expanding or contracting. And what you see across both Dallas and Tarrant County, as you look toward the right side of each of those panels, which would be the most recent weeks, that as we were entering the mid to later part of the summer, the RT value was substantially above 1. That was the foreshadowing. What we have seen is this marked increase in the number of newly infected individuals. The encouraging news, and this goes back, I think, to at least by temporal correlation to what you saw about masking trends, is that in just the last week or 10 days, we have seen the RT now beginning to fall and is hovering just above 1. If we go to the next slide, you now see both the course of the number of hospitalized patients in this slide, Dallas County. In the following slide, you'll see Tarrant County over the past months and what is projected in the weeks ahead. So the black dots represent actual data points, how many patients were in hospitals at a given point in time. And you see, of course, that peak in January, which was the largest surge to date. If you look toward the right end of the curve, you see black dots with an overlying blue line. The blue line was the number of hospitalized patients that were predicted by the UT Southwestern model. And the black dots are what actually happened. And I think you can see how closely the black dots actually lined up with the projected blue line. And so with that sense of how closely the prediction has been reflected in actual experience, you see the blue line projected from the end of the black dots. This is now to the far right of the panel. And you see that in conjunction with that change in RT, with that change in masking behaviors, that we may well be, at least in Dallas County, seeing the crest within the next couple of weeks of this latest surge. The blue shading reflects the possibility of changes. You know, if, for example, for whatever reason, there was a collective move not to mask at all beginning tomorrow, just to give a extreme hypothetical. But as you can see, again, from past experience, what we are expecting is the path that you see in the blue line itself. Next slide. This is the projection for Tarrant County. Obviously, it shows a somewhat different expectation in Tarrant County, where, again, masking is at least 20% lower than it is in Dallas County. And it shows a continued increase in the number of individuals who will require hospitalization, barring any substantial short-term change. And that would necessarily mean a large uptick in compliance with masking recommendations. The next slide. This is now a model projection of the further course of the current trend we're in, the current surge we're in, depending on a number of variables. So at the left panel, and in particular, further uptake of vaccination. So on the left panel, if you look at the yellow line, it's more or less what you saw in 2 slides ago and what's projected for Dallas County. And on the right panel, you see how that can be further attenuated if there was at least if there was a twofold increase in vaccination rates. Now, as we went into August and the later part of August, we did see an uptick in vaccinations, along with that increase in reported masking. I will say within the last week or 10 days, that has been tapering off, and we are more or less seeing, at least in our experience on the campus, which reflects what is happening more generally in the county and North Texas, kind of a moderated increase in the number of individuals choosing to get vaccinated. But you can see here again that some the profile of the pandemic is not inevitable. It is influenced by a number of key variables that we collectively have the opportunity to influence. The next slide, please. That brings me to the end of the overview. As I mentioned in my initial comments, this model is updated twice a week and posted publicly on our website, where you can also find other resources, some of which Julie touched on. And with that, I'm going to hand things back to you, Lisa, to moderate questions for the remaining of our time.
Thank you both. That was a lot of really useful and helpful information. We have received a lot of questions in the chat. Obviously, we're nearing the end of the hour, so I want to let everyone know a couple of things that came up multiple times. We will be sharing the slides afterwards. There will be a recording made available. We'll send this all in a follow-up email. We'll also try and gather all of the frequently asked questions submitted beforehand and in the chat that we aren't able to get to in this briefing, and provide answers for those as well. Dr. Podolsky, the first couple of questions I'll ask you. Can you tell us what has UT Southwestern done to meet the challenges of the pandemic? And a related question that we received multiple times is, how can we in the community help UT Southwestern and our healthcare providers meet the challenges of this pandemic?
Well, thanks for both of the questions. Certainly, since the pandemic first landed here in North Texas, as a institution and as a community, we've been intensely focused on what we can do to provide for the needs of our patients, support the community, and advance our mission. So what that has meant is caring for literally thousands upon thousands of patients in our own Clements University Hospital and at our partners, individuals who were ill enough to require the care that can only be provided in a hospital, but even a greater number, tens of thousands of individuals who were infected with COVID, but fortunately not ill to the point of requiring hospitalization. So providing care for our patients has been at the forefront of what we do. Also providing important kind of supportive capacities that not only served our patients, but patients of many of the other health systems here in Texas, including testing, actually doing that to support the state, and providing vaccinations. At this juncture, we've provided more than 270,000 vaccinations, and as Julie reminded everyone, still available for those who haven't yet raised their hand, but decide to make that important step. In addition to taking on COVID directly, as an academic medical center, our scientists rolled up their sleeves along with our physicians and have initiated more than 350 research projects, which range from testing new potential treatments to finding the underlying molecular causes of COVID-related disease. Finally, we have done everything we can to be a resource of information. Hopefully this briefing is an instance of that, while we are doing everything we can to keep both our patients and our own UT Southwestern community safe. So we are, a deeply committed, dedicated organization as a team to really meeting the challenges across the entire continuum that we find them. In terms of helping our caregivers, first of all, I'm very, very grateful that so many of our friends have stepped up and generously provided funds and support in the form of meals and others and other ways to support the front lines. And I can't tell you how meaningful those efforts have been to the teams, which have been really at this now nonstop for 16, 18 months. I think to the question of how you can support the caregivers, the thing that has to be at the top of that list is, if you haven't gotten vaccinated, get vaccinated. If there are those around you who trust you, convince them, try to persuade them, answer their questions, or point them to information which will address their concerns, and encourage in the near term. The most important thing in terms of is helping to stop the spread of the pandemic, and that does include wearing masks while we're in the midst of this surge.
Thank you. Just for everyone to know, we're going to take 2 more questions and then we will have to go ahead and wrap up because we're nearing the end of the hour here. So Dr. Trivedi, I'll ask this question to you. There have been some unfounded rumors and fears about vaccination potentially affecting fertility, even though those are not based in fact. How do we convince women of childbearing age that it is safe to get vaccinated?
Yes, thank you. I think that's a really great question. So there have been numerous studies that have basically reviewed thousands and thousands of women, I believe about 30,000 women who were vaccinated. And basically individuals who were vaccinated, there was not an increase in the number of miscarriages that occurred in the vaccinated group compared to those who were not vaccinated. And what we have been seeing, especially more recently, is that many pregnant women are either undergoing preterm labor, sometimes losing their own child or losing their own life because they were unvaccinated and became infected with COVID-19. So we've seen some really significant impact of COVID-19 on our pregnant population. And, you know, if there's ever a desire to be able to have another child in the future, the one way you can guarantee that is to make sure that you don't actually die from COVID-19 or end up severely ill. So plenty of studies to show that it was safe in pregnant women.
Thank you, Dr. Trivedi. And then the last question, multiple people have asked in different variations of, can you tell us about herd immunity? Has the goalpost been moved thanks to the Delta variant? We know lots of people have been infected and vaccinated at this point. How close are we to herd immunity is important for everyone to keep getting vaccinated.
Yes. So to answer that bottom part of it, yes, it's very important for everyone to keep getting vaccinated because the only way we're going to get immunity is either through infection or vaccination. And, you know, vaccination is going to be the preferable way. As far as the goalpost, you know, I think early on, people have been talking about 70%, 80% of people being immune. But what we found is that even people who were infected with COVID-19 in the early stages of the pandemic were still becoming infected with the Delta variant. So I would say that, yes, we do need to have higher percentages of people immune, and, you know, probably upwards of around 90% or so. And part of that is also due to the fact that the Delta variant will infect so many more people from each infected person compared to some of the original variants. So it spreads very easily and it can cause infection in many people.
Thank you both so much for your time today, for all of this valuable information. As I mentioned before, we'll circulate all of these materials in a follow-up email to everyone that registered in the coming days. So thank you again and have a great rest of your day.